Alrighty, so my name is Corey Robertson. For those of you that don't know, I'm one of the anesthesiologists here. And we're going to go over today some stuff. Oh, I haven't even downloaded my PowerPoint yet. Hold on, we're not ready yet, but we will be soon.
The random anesthesia topics.
So the random anesthesia topics part, or RATS, as I like to call it. So this is the start of like a series of lectures. This started out, I actually talked to Danny a long time ago about starting some sort of educational series for the nurses in PACU because they weren't getting, there was just a kind of a void there. And they weren't getting a lot of, they weren't getting a lot of like education, I guess. Yeah. And so he wanted to kind of start that thing. And so I drug my feet. Here we are now. And so Ashley's been helping me out a little bit with it. And she's one of the nurses over here. And so anyways, that's kind of how this started. The goal is to have a lecture every month for mainly centered at PACU nurses, but there's absolutely no reason that it wouldn't apply to pre-op nurses or anyone kind of surrounding the OR, or just people that really dig lectures about anesthesia. So today, like I said, this is going to be ridiculously basic. I'm going to pivot here. I'm going to go over different types of anesthesia, kind of sort of what anesthesiologists do in general, the phases of anesthesia care, what the depth of anesthesia even means, and we're going to have a little bit of talk about drugs, not very much, because that's less, I guess, what you guys are doing, and more just the phases and what that looks like. That's what y'all are going to see a lot more of. So I made sure to write this as small as possible so no one can read it. So when I was going through residency, we talked about different phases of anesthesia care, and as part of what an anesthetic in general kind of is. So the big thing we hit on is there's 4 pillars of anesthesia. You have to have analgesia. That's proper anesthetic care. Absence of awareness or amnesia is another one. And these 4 things are mainly talking about a general anesthetic. So there's caveats to these. The third one is control over the autonomics, control over blood pressure, heart rate, all those sorts of things. Breathing is also included in that. And immobility, because if you meet all those 3 things and the patient's just gyrating, it's not gonna, we're not gonna have a very good surgery. And so different types of anesthesia. General anesthesia, this is what everybody kind of is familiar with. This is the go back, go unconscious, get intubated, that sort of thing. That meets all of those criteria, usually. Regional anesthetic. And neuraxial is a type of regional. Neuraxial anesthesia is spinals and epidurals, pretty much anything that affects the central nervous system, mainly the spinal cord, right? We don't really like doing neuraxial anesthesia that affects the brain. That has a whole different set of problems with it. So neuraxial is spinal cord, is what I'm trying to say. Regional anesthesia is peripheral blocks. So brachial plexus blocks, pop SAF, those sorts of things. That's all regional anesthesia. We don't do a lot of regional anesthesia per se here in the type of anesthetic. In what I'm talking about, we do a lot of regional blocks, which is regional analgesia, but not necessarily anesthesia. So a regional anesthetic would be one where we go back to the OR, we do a block there, and the patient lays awake while they get, hand surgery or something like that. Like I said, we don't do a whole lot of that here. We do a lot more analgesia. So postoperative pain control is what I'm talking about. And then there's monitored anesthesia care, which has become kind of synonymous with sedation. Those two things are not the same. We know what sedation is. Endo guys, y'all do it all the time, right? We're going to give a little of this, a little of that. The patient's going to still be kind of conscious. We'll go through that in just a little bit. But the goal is just to sedate, not necessarily a general anesthetic. Monitored anesthesia care is technically just an anesthesiologist monitoring a patient. So that can include sedation. It doesn't have to. I've done monitored anesthesia care where I give absolutely nothing to the patient and I just kind of look at him. It's typically a situation where somebody either doesn't need to go to sleep, like some of our awake craniotomies that we do, or a situation that can decompensate rather quickly and you want an anesthesiologist there to kind of pick up the pieces as that goes on. So those are the different types of anesthetic. What I want to talk to you all about now is different phases of anesthesia care. So there's 3 phases, for those of you that didn't know. There's preoperative, intraoperative, and postoperative. We have that divvied out very clearly. Preoperative takes place in pre-op or same-day surgery. Intraoperative usually takes place in the OR, though not always. Postoperative comes here to PACU, or sometimes it's the floor, sometimes it's peds, sometimes it's downstairs in holding, lots of different places. So the preoperative assessment, here's kind of what I do as an anesthesiologist. This is technically an H&P. It's a crappy H&P, but it's an H&P. I love being an anesthesiologist because I kind of get to cheat. I use lots of other people's H&Ps to determine kind of what mine will look like. And our notes that we put in the chart, not very good notes. If you look at our preoperative assessments, it's a lot of stuff that's artificially brought in, at least on Meditech at this location. And not necessarily something that we're freehanding. Back in the day where we used to like handwrite stuff, it looked a lot more organized. Or maybe it didn't, I don't know. So this is where we meet the patient, a lot of times for the first time. We go over different anesthetic choices for the patient. Today I'm going to be doing, after this little lecture, I'm going to do total knees and total hip replacements. I'm going to give some choices as to whether or not we need to do neuraxial or a general anesthetic. I'm going to talk with the surgeon as to what their goals are, things like that. We go over the risks and benefits with the patient. And different strategies to reduce risks as well. And so some risks we can mitigate, some risks we can't. After presenting choices to the patient, we kind of decide on a type of anesthetic, and I put it after this, but like kind of the whole time we're doing this, we're doing a physical exam. And a physical exam for an anesthesiologist may not necessarily involve a lot of hands-on with the patient. A lot of it's just looking. A lot of the airway exam, which is one of the more important types of exams for us, is looking for presence of retrognathia, looking to see if there's any teeth or speech problems. Do they have cranial nerve deficits that we're going to have to mess with? Is there any asymmetry in the face that could indicate maybe a difficult intubation? But our physical exam does include mainly the airway, heart, and lungs, right? So we do a little listen, make sure everything's good. If they have any crazy murmurs that have never been documented before, that may be of concern. So we formulate the perioperative plan with the patient. And then after all that's said and done, we assign an ASA classification. And I know you guys as nurses have probably seen a lot of like, what ASA is this? And somebody throws out some crazy number maybe you weren't expecting. There's a little bit of wiggle room, especially with different ASA classifications. So these are the different classifications on here. They go from 1 to 6, okay? An ASA 1 is a normal, healthy patient with no medical problems. The great Carl Tinlin once said there's no such thing as an ASA 1 patient because they're coming to the OR for a reason, right? So they have to have some sort of problem that they present to the OR with. I don't necessarily agree with this. Over at Health Center or Logan North, we do a lot of cosmetic stuff. So people come in with absolutely no problem whatsoever. They're still getting a surgery for something. So I don't refer to that as a medical problem, but ASA 1s are not very frequent. ASA 2s and 3s are where we see, I don't know, 95 to 99% of our patient population. ASA 2 indicates mild systemic disease. These are smokers, alcohol drinkers, anyone with like hypertension, diabetes, well-controlled disease processes. And so as we accumulate a lot of those, somewhere there's a line, and it's kind of a judgment call by the anesthesiologist as we go forth into ASA 3 territory. This would indicate severe systemic disease, uncontrolled disease process, significant functional limitations, or multiple moderate to severe diseases. So honestly, if you look at ASA 2 on here, it says smoker, alcohol drinker, hypertension, diabetes, obesity, asthma. If somebody had all of those and it was something they took a lot of medications for, you could talk me into calling them an ASA 3. But just a couple of those things in isolation don't necessarily make an ASA 3. If you get 10 anesthesiologists in a room, present a patient that's somewhere in between those, you'd have 5 anesthesiologists call them a 2 and 5 call them a 3. This is like the age-old debate amongst anesthesiologists as to which one those are categorized in. By the time you get to ASA 4, it's a little more cut and dry. This is the language used to describe this is a constant threat to life. And so anyone with significant O2 requirements, multiple liters, they get real winded doing stuff, they have a decreased ejection fraction. It also states anyone within 3 months that has had either a stroke, an MI, or stents placed. That is still considered unstable disease and a constant threat to life. End-stage renal disease is another one. I consider those patients to be an ASA 4 because if you're end-stage renal disease and you're on dialysis, you're having these huge swings of electrolytes and stuff all the time. I consider that to be a pretty constant threat to life that you're mitigating. Other anesthesiologists may not for that specific disease process. ASA 5, these are your traumas and just nightmare patients that come in. Massive trauma, ruptured AAA, intracranial bleed, dead bowel, all those different things are ASA 5s. The weird debate nobody's ever really explained to me is at the bottom of this, we also have a modifier, I guess you'd call it, with an E at the end. E stands for an emergency case. And so the way that's described in the literature is any delay that would lead to a loss of life or limb, any body part that's gonna get ischemic and die off, anything like that is considered emergency surgery. This is where we waive NPO requirements and we just go to the OR. And so pretty much any ASA 5 is probably an emergency. Yeah, I'm sure there's maybe reasons it wouldn't be, but it's pretty much an emergency. These are also patients on pressors, things like that. Anyone that's intubated, I'd probably call an ASA 4 or higher. Those sorts of things. ASA 6, you rarely see. This is exclusively used for organ procurement procedures. It's more of a billing thing for us. And so this system is not necessarily designed to explain. It was originally probably was designed to have some constant measuring stick for how sick a patient is. But I've taken care of ASA 3 patients that were way healthier than some ASA 2 patients for multiple different reasons. Same thing with between a 3 and a 4. I've taken care of patients that might meet criteria for a 4 that just eyeball a whole lot better than some ASA 3 patients. So it's an imperfect system. We realize that, and we just kind of move along with it. So this I thought was cool to add in here. This shows basically as your ASA class increases, so does your mortality risk. This was a study done 2012, so not even too terribly long ago. And it just kind of looked at the different risks of surgery and what your mortality looked like. Obviously, ASA 5s have a much higher mortality rate than say a 1 or a 2. 1 and 2 are pretty much equivalent. You get up there a little bit with a 3, especially on that red line that you see, which indicates high risk surgery. It can be above, I think on here, it's above 50% for an ASA 5. I probably should have gone over what surgeries are high risk and which ones aren't, but I didn't. So here's, so that's the preoperative phase. We look at all those things. So intraoperative is usually, like I said, when we go to the OR, this is the actual surgical phase. So the first phase, the 3 different phases are induction, maintenance, and emergence, okay? Maintenance is the longest stage that we go through, and we can keep maintenance going forever. Induction, hopefully that doesn't go on forever. Emergence hopefully doesn't go on forever. But maintenance is kind of the long one. For induction, anyone that's been in an OR has probably witnessed this happening. You can do either an IV or an inhalational induction. IV induction is where we give drugs through the IV to make you go to sleep. Inhalational induction is where you breathe, typically sevoflurane or something like that, to go off to sleep. The requirements for induction, often a lot different than maintenance, mainly because I've got to make you profoundly deep a lot quicker. And so we use big doses of things to kind of get you there a little faster, to make that steady state in your brain, which is where all of our drugs are affecting, a little bit quicker. We usually use hypnotics, analgesics, and a lot of times paralytics to achieve this. A hypnotic would be propofol, etomidate, ketamine. All of those are hypnotic drugs. Analgesics, opiates, fentanyl, Dilaudid, morphine, all those things. Sometimes we don't necessarily need to use those either, but a lot of times we do. And then paralytics, succinylcholine, anything that ends in curonium. Pancuronium is kind of an old one, but the ones we use now, rocuronium. Some people still use vecuronium. Rocuronium is a big favorite amongst people because you don't have to mix it up in anything, and it's reversible with Sugamidex. And so the maintenance phase. Once we're done with induction phase, we'll usually establish an airway at that point in time if we need to. And then the maintenance phase. So this is either IV or inhalational as well. The requirements are typically a little bit lower than an induction phase because after a while you kind of reach this steady state. Yes, ma'am?
You guys do both, though, a lot of times, IV and inhalation.
We do. We usually put people to sleep with IV and then move over to inhalation. Okay. Sometimes anesthesiologists will do both at the same time. We'll have them breathing anesthetic gas and maybe an infusion of something going. Propofol, Presidex, that's a popular adjunct. And so, yes, you can blend these. They're not mutually exclusive. And so the inhalational agents that we use here are sevoflurane, isoflurane, and I forgot to write desflurane on here, is another one. Isoflurane is pretty much exclusively used in the heart room. Sevoflurane and desflurane are pretty quick on, quick off agents that patients just breathe off on their own. And that's how it's metabolized. Sevoflurane is the highest metabolized drug in the human body. 2 to 5%, depending on what study you look at. That's all that the human body metabolizes it. Desflurane, I think, is like 0.1% or something ridiculous. Well, how do we get rid of it? We breathe it off. That's how it's eliminated from the body. You don't need a liver, you don't need lungs. I'm sorry, you don't need a liver, you don't need kidneys. All you need is lungs, and you can eliminate the drug. So that's another reason it's really kind of famous for it. And newer technologies allow us to keep people asleep for a long period of time for really cheaply, which makes everybody else happy. And then the emergence phase. And this is where we bring the patient to PACU. They're still kind of waking up. They go through different stages of sleep and emergence, which we'll go through here in just a second. But the emergence phase is where we kind of wake the patient up. They're breathing on their own. We get the airway out, typically, and get them to a place where they can continue their recovery, which can, last anywhere between 5 minutes and 45 minutes, maybe even longer. So here's the different stages of anesthesia depth. We talk about stage 2 a lot. Stage 2 is kind of the scary phase, but we'll go through the different ones. Stage 1 is kind of an analgesic stage. Patient's conscious, but they have a decreased perception of pain. This is your conscious sedation patients, right? They're kind of snockered, in other words, a little drunk. Stage 2 is a delirium phase. Patient's unconscious, but the body is very reflexive. They have an irregular breathing pattern. They can breath hold. Different things look weird. This is the stage where patients laryngospasm. This is the stage if you're doing an inhalation induction with a pediatric patient that you go to start the IV and their arm moves. They're unconscious, but they have these reflexes still going. And so that means that they just haven't built up a good concentration of whatever drug you're using in their central nervous system to for you to be able to do all these things. Stage 3 is our goal. This is where we want surgical anesthesia. Most general anesthetics, well, I don't know about most, the inhalational general anesthetics do provide some degree of muscle relaxation, and so this is where you see that. They're not usually moving. They don't usually have reflexes, big reflexes, I mean, and most often don't have the ability to protect their airway. And so this, like I said, is our goal. This is the intubated patient undergoing a lap appy or something like that. As you advance with these drugs, you can reach kind of a cortical burst suppression, right? I can put you in kind of a coma, in other words, not really brain dead state, but like everything kind of goes quiet in terms of your brain waves. And we call that stage 4. That is medullary depression. And there's also a depression of a lot of the cardiovascular reflexes and things like that. You'll get pretty significant hypotension. That is not our goal. Sometimes we have to advance things to doses that kind of flirt with that stage 4, but that's not something we strive for, in other words. So here's the continuum of sedation. So this is important for anybody trying to give like conscious sedation and things like that. So I took this, by the way, everything I've used in this, all these graphs and things, I stole from UpToDate. I steal a lot of things from UpToDate. It's a really cool resource. It's for free in this hospital. So if you go to uptodate.com, it knows you're part of Logan Health and you can just look at anything you want. If you've never used that website, it's amazing.
You can get it on your phone too.
You can get it on your phone. You can set up a username. And I think it's every 30 days you have to log in from here in order to use it or whatever. Anyways, so I got this from UpToDate. So this goes through different depths of anesthetic, right? Or of sedation, all the way up to general anesthesia. So minimal sedation is basically pre-med. We give you a little bit of first ed, you slur your speech maybe a little, otherwise you look pretty normal. And that is minimal sedation or anxiolysis. Moderate sedation, also known as conscious sedation. We do this a lot in endoscopy and for like really little procedures. This is the main thing to look for here is the patient is still responsive. They're purposeful. They have a purposeful response to either verbal or tactile stimulation. So if you touch them and they open their eyes, that's still conscious sedation. You can talk to them. Sometimes they talk back. Sometimes they just make noises, but that's still a response. Their airway is usually not compromised at all. Even, well, maybe in someone with sleep apnea or something like that, but usually not. You get into deep sedation, and really only anesthesiologists should be providing deep sedation as a goal, but I'll get to that in just a second. Deep sedation is really only a response to painful stimulation, and you may actually need to help out with the airway a little bit, and that's why anesthesiologists should be doing that. They may not be ventilating real well. We do this, or if I'm taking care of them, I do that a lot in endo. It seems like I might have a little heavy hand, but a lot of times I need to help them, sometimes with their breathing. And then general anesthesia, we kind of went over earlier. Airway interventions often required. The definition of general anesthesia on this spectrum is that they're unarousable to a painful stimulus. So if you can do a jaw thrust and they don't really do anything, they're under general. The reason I say only anesthesiologists should be doing deep sedation is you need to be able to, whatever your training is, whatever your goal of sedation is, if your goal is to provide conscious sedation, you need to know how to handle deep sedation as well. So if your goal is deep sedation, you need to know how to do a general anesthetic, because there's not a whole lot of wiggle room sometimes, and you are violently thrust into that world. So those that are doing conscious sedation, correct me if I'm wrong, but endo requires you to be able to handle airway stuff and things like that, just in case, right? So those are the sort of things that we look at with that continuum, I guess you'd say. Okay, so we're done with the intraoperative phase. We go on to postoperative care. I'm real brief on this. Postoperative care, for our purposes in this lecture, phase 1 usually takes place in a PACU setting. It needs a certain nursing ratio, and you need to have monitoring, those sorts of things. Patient could still be unconscious. Patient might be a little bit arousable, but definitely not good enough to just leave the room and leave them on their own. Once they meet criteria to go to phase 2, that just takes place somewhere else. Phase 2 can be in this facility. They go over to same-day surgery at Logan North. It's like 2 rooms over. Sometimes in the exact same bay, you do phase 2. This is a conscious patient that can, sit up, drink some water, or that sort of stuff. What's up?
Well, so I have a little bit of an issue with the phase 2. Like sometimes I'll come out of OR wide awake and we'll say, "Oh, can you be phase 2?" to the anesthesiologist, and they'll say, "Well, I had an LMA." But that doesn't matter because they're meeting criteria.
Correct. So technically, the type of airway you use has nothing to do with what phase you are. And I'll do my best, but you're never going to get in trouble phase 1ing someone that kind of already meets criteria.
Yeah.
The fear with that, mainly from a historical perspective, is we didn't have any real short-acting inhalational anesthetics. So more often than not, someone that says, oh, they had an LMA, they were undergoing an inhalational anesthetic. Inhalational anesthetics are a little more dirty than like propofol and things like that. They don't necessarily provide a real linear recovery. And so you can kind of wake up and go back to sleep and things like that. And so I can definitely understand why someone... I'm a lot more comfortable when I take an airway out and they go to phase 1. But I also bring patients like really unconscious to PACU. I lean on you guys probably a little more than I should. But yes. So I don't have a good answer for you. If an anesthesiologist says this needs to be phase 1, I'd do it as phase 1.
Yeah, and then we watch them for about 10 minutes and they are still phase 2-ish, then we move them to phase 2.
That sounds great. You're never going to run into problems with that.
Okay.
It may be kind of a pain in the butt. It may be inefficient.
Yeah.
And that's, I don't know, maybe a different debate. But
Yeah. I'm just
there's no cut and dry, this is what this should be. But I'm just telling you what it usually is. So phase 2 can also be like we were just kind of talking about. Patient comes out, they're talking, not necessarily walking, but like they're ready to start eating food and doing these different things, getting them ready for discharge type stuff. Some people wake up a lot quicker than others. Some people wake up and never go back to sleep. Some people wake up and go back to sleep and are unarousable. That's all phase 1. Phase 2, in endoscopy here, we can send it back to the floor once they meet phase 2 criteria. A lot of stuff done in endo is IV based, and so it's a little bit more of a linear recovery. It's a more predictable recovery. We take them back to same-day surgery to do phase 2, those sorts of things. So that's kind of how post-op works. That's all I got for today's purposes.